Buenas tardes, welcome. First, I want to thank CIIIEN and the jury for considering our job for the award. And I'm here on behalf of a group of people, a team who has worked hard in this project, and I also want to thank them. I'm a neurologist. I work in CIIIEN, HM Puerta del Sur, a neuro research facility led by Dr. Obeso. And our main objective in CIIIEN is to stop Parkinson's disease. One of the tools that we do have to do so is ultrasound, focus ultrasound, which basically is an ultrasound transducer, which is this one, with more than 1,000 beams of ultrasound that is compatible with an MRI. By focusing or by directing these 1,000 beams of ultrasound to a certain target, we are able to do deep brain thermoablations in deep brain structures. The main advantage of focus ultrasound is that we can do these lesions without the need of surgery. We don't need to open the skull to do these lesions. This is a novel technology. Okay, gracias. Okay. This is a novel technology, even though it's the combination of two classical concepts. The first one is the history, decades of history of ablative neurofunctional surgery. At the time, decades ago, lesions were made to treat neurological and psychiatric conditions, but it was needed surgical intervention. And the other concept is the use of ultrasound to do those lesions. It was pioneered in the 50s by the five brothers in Illinois, and the main limitations at that time were that an acoustic window was needed because the beams could not pass through an intact skull, so surgical intervention was needed, and there was no radiological guidance. There was no MRI, so the accuracy of the lesions was pretty low. Now, we have overcome these limitations, and we can use it in clinical practice. I'm going to show you briefly how it works. This is the patient in here. You can see we can assess the patient before going into the MRI. Then we place a frame in his head in order to prevent movement during the treatment. And then we place the patient with the frame on the MRI attached to the transducer. Then the next step is the targeting. We direct all the beams to a certain target that we know that we have to impact on to have a clinical effect. And once we know that we are in this target, that we are well placed, we start with sonications. Take a look to this hand, okay? It will be shaking when I start the video. And then look also here when the temperature curve will start rising, okay? So we start delivering energy, the patient is shaking, temperature starts increasing, pam, pam, and tremor stops. Okay, so here, this is an effective sonication. We have increased the temperature at that nucleus, and we have, I like zooms, I'm old-fashioned, and then after that, we can assess the patient all the time. We can go in and out the MRI, and this is a very well controlled manner of doing a lesion. We can even do tasks or whatever. The first milestone with this treatment, what's happening? The first milestone was in 2016, this randomized controlled trial by the Virginia group. They showed that a thalamotomy, an ablation of the thalamus, was superior to a sham procedure for essential tremor. The sham procedure was the same. They placed the frame, they placed the patient in the MRI, they pretend to deliver energy, but the energy was switched off, and the patient did not know. So it was a double-blinded, randomized controlled trial that showed this difference between the treated and non-treated group, and that allowed approval by the FDA. In the United States and worldwide, it can be done in clinical practice. The second milestone, this one patient the first patient of Parkinson's disease that we treated, the second milestone was similar, was a randomized controlled trial, but with Parkinsonian tremor. Here you can see this patient. She has tremor in the left hemibody, and then we made a right thalamotomy, and the day after, she had no tremor. This is off medication, so there is no effect of medication in this case. And this effect, we have been following this patient for almost 5 years, and the effect is sustained, it prevails. So with this trial, again, the FDA approved the use of the ultrasound to perform a thalamotomy for Parkinsonian tremor. But what happens with Parkinson's disease? Because we know that Parkinson's disease is not only tremor, it's also rigidity and bradykinesia, or slowness of movement. And a thalamotomy improves tremor, but it does not improve the other motor features. Well, we know from those decades of ablative neurosurgery, we know that to impact on the other motor features, we have to go either to the pallidum, either to the subthalamus. So we have to make a lesion to impact on one of those nucleus. And some of you will be thinking, why doing a lesion improves symptoms in any disease? We know well that in the Parkinsonian state, both the GPI and the STN have an abnormal activity. And this abnormal activity is related to the symptoms. So by abolishing this abnormal activity, the symptoms improve. In fact, medication, as can be seen here, medications improve this activity as well. So this is the mechanism underlying the benefit of doing a lesion in this nucleus for Parkinson's disease. Okay, so in April 2016, in Móstoles, in ICCINAC, we thought, is focused ultrasound subthalamotomy possible? We didn't know at that point. Is it safe and effective? And is it better than medical treatment? We decided to go for the STN because it is well visible in the MRI, because it has a good location for focus in the ultrasound beams, and because we know from the evidence, again, of the neurosurgical evidence, the previous neurosurgical evidence, we know that this is the most effective target for Parkinson's disease motor features. So we designed an open-label study, 6 months follow-up, with 10 patients who were asymmetrical, because we were doing only unilateral lesions. We assessed several motor conditions, several motor things, and of course side effects. And the primary endpoint was improvement in the UPDRS-3, which is the scale that we use to assess the motor condition of the patients. We made other complementary tests. I will talk about them after. This is the first patient that we treated. These are the main baseline characteristics. And look at this patient. He was 50-year-old, very asymmetrical, tremor, rigidity, and akinesia on the right side, as you can see. And this is before treatment of medication, again. And this intra-procedure, there is Professor Obeso assessing the patient. Then we delivered the sonications, we made the targeting, we delivered the sonications, the energy, and you will see what happens immediately after the procedure. You will see how the patient is. This is just after the patient went out from the MRI. No tremor in the right side, rigidity has improved, and akinesia as well. In fact, the patient has become symmetrical. You see here, both in the arm and in the lower line. This is the day after, again, still off medication. He has been off medication for 4 or 5 days almost. And, well, again, we have been following this patient for 3 years, 4 almost, and still there is a sustained effect. So, this 10 patients trial was published in Lancet Neurology last year. In here, we showed that STN focused ultrasound subthalamotomy was feasible, was safe, and we show preliminary data that it was effective. In fact, you can see here the UPDRS of the treated body side. The blue bar is the treated side, the red bar is the non-treated side, and you can see how at baseline there was a big difference between both sides, and after the treatment, the treated side decreased a lot, and the patients become practically symmetric. The last follow-up is 6 months. So the effect in this case was sustained for 6 months. What we show was a sustained effect for 6 months. The decrease in the treated body side was more than the 50%, which is a huge decrease thinking in medical practice. These are all the patients, and 6 patients improved more than the 50% of their motor signs. And this is the total MDS UPDRS, which includes not only the treated side, but also axial and contralateral features. There was a 35% reduction, and this allowed a decrease in medication of the 24%. If we separate between motor features, which is tremor, rigidity, and bradykinesia, rigidity and tremor were those who improved the most, and akinesia a bit less. This is what happens also with deep brain stimulation. With deep brain stimulation, we have larger improvements with rigidity and tremor. And this is how lesions look like. Here is the STN, and you see the day after procedure. You see how the lesion is here. It has a lot of surrounding edema, which is inflammation, that with the follow-up, it disappears. And in the end, there is only very small lesion here, which has sustained effect. This is the decrease in the lesion volume. And what about side effects? Well, most of them were transient and disappeared within the first few weeks because most of them were related to the edema, not to the lesion itself. And we did have this patient that developed this dyskinesia in the treated side because it was like going to the opposite side of Parkinsonism. We have Parkinsonism, we treat him, and we went to dyskinesia. What did we do? We decrease medication, we wait for the effect on Parkinsonism remain. We decrease medication, we just wait for a few months until the last follow-up, and here you can see the patient. There is no dyskinesia, practically not, but the effect on Parkinsonism is still there. We also perform cognitive assessment. Any patient show any decline in any domain of cognition, which is very important, of course. You can see the patient walking. And, well, we ask the patient, these type of scales are increasingly used because they give an overview of how the patient feels after the treatment. And we ask the patient whether they were, well, the range is between much worse, very much worse, or very much improved. Well, one patient said that he reported no change. In our opinion, he had improved a bit. Another patient said that he has improved a little, and for us was much improved. In 4 patients, we did agree that were much improved, and the other 4 were very much improved, and the patients agree with us. This is not very scientific, but it gives it's representative of real life in clinical practice. So, which is the mechanism underlying this improvement? We made FDA PET to show the metabolism of the motor pathway, and what we saw was that the typical hypermetabolism related to Parkinsonism in the motor pathway was reversed. So, the lesion decreased the metabolism, of course, in the STN, also in the GPI, which is the output of the STN, and also in cortical motor areas, which are the projection of the GPI. So the mechanism underlying this, again, is the reduction in this abnormal or excessive activity, which is in the pathway or in the motor pathway of Parkinsonism. Well, so in 2011, this technology came out, and we had a tabula rasa to fill. In the last few years, there has been some evidence. Part of this evidence is the trial that I just presented, but still there is a gap, and there is something to fill, and we have to fill this gap with more evidence. And this is what we are going to do. We are trying to do in CIIIEN. We have designed, in fact, we have finished this trial. We're in the phase of data analysis. We have designed a randomized controlled trial like those of tremor. We took 40 patients. Some of them were treated. Some of them were pretendedly treated. And we aim to compare that at 4 months and see whether there is a difference in the motor status of these patients. These patients have a lot of assessments. I'm going to show you one of them. We place a device, like motor sensors, all over the body of the patients, and we analyze the movement of these patients. This is an avatar. You can see here how the patient shakes in the right hand, and the arm swing, which is reduced. Also, the stride is a bit reduced. This before the treatment, and this is the same patient after the treatment. And you can see that he or she, I don't know, is not shaking anymore. The arm swing has improved, and the gait is more normal. This is an image or a video, but you can extract the data to have an objective assessment of movement with this software. Sorry. Okay, so this is the first time I show this slide in public. This is the initial preliminary results of this trial, of randomized trial. So don't take it too seriously because we have to analyze the data. But what we saw was that the treated group improved up to 50% in the treated body side, while the sham group, the group that has not really been treated, improve only 15%. I don't have the statistics. And if we separate between tremor, bradykinesia, and rigidity, again, there are larger improvements for tremor and rigidity and a bit less for bradykinesia, but still there is an improvement. And we want to continue after this trial. We'll do more trials. The next trials will be focused on bilaterality. Of course, Parkinson's disease and also essential tremor are bilateral conditions. So we want to see whether a bilateral lesion can be done. We still don't have data about this, but it's quite data enough. It's quite feasible that it could be done. And we also want to see whether if we treat a condition, a neurodegenerative condition like Parkinson's disease, if we treat it in the early stage, we will be able to modify disease progression. This is ongoing. We don't have any data so far, but probably in the next few years we could tell you something about it. Gracias.
So very interesting. Thank you very much. So it is not clear to me what is the advantage of this method versus deep brain stimulation, because in addition to the surgery, of course, you mentioned, but in terms of how long you have to do surgery or treatment, and whether the inclusion criteria of patients is the same or different.
Well, the main advantage, of course, is that we don't need surgery to do this. I mean, deep brain stimulation is an excellent treatment, very effective, it's well proved, but it has the potential complications related to the surgery, and also to the fact that you have to wear a device, and the patient has to wear a device, and also to the fact that this device can, for instance, have an infection. So the main advantage, which is not a small advantage, is not having to do surgical intervention. This also not only, but also could allow patients who are not candidates for surgery to make a procedure like this. So, well, there are a few which are big advantages in our opinion. But I must say, this is not deep brain stimulation or focused ultrasound. In my opinion, it is like deep brain stimulation and focused ultrasound in terms of therapeutic armamentarium for PD.
Thank you very much. So I have two quick questions.
Mm-hmm.
So the first is, so this treatment is specifically for tremors.
For?
Tremors.
Tremor.
No?
Not only. I mean, it can, if you impact on the thalamus, you have an effect, a significant effect on tremor, but depending on the target, you can have effect on other features. But it has been tested so far mainly for tremor.
Okay, so but the degeneration still remain there. So did you follow longer time the patients? What happened with the neurodegeneration?
Yeah, this is a good question. In fact, this is what we want to do with this early focus protocol. To test change in the neurodegeneration, you need to impact early in the disease, because after 10 years of disease diagnosed in Parkinson's disease, there is practically nothing to save. So we want to test whether impacting making a lesion early in the disease could change this neurodegeneration or slow this neurodegeneration. In any case, it's not advancing neurodegeneration. Mm-hmm. I don't know if the question was related to this. It's not advancing. It doesn't go faster, neurodegeneration, because of the lesion. We want to test the opposite, in fact. Okay.
And the second question, quick questions. Can you imagine the use of ultrasound for other neurodegenerative diseases?
Sure.
For example?
It's already being used in different mechanisms, but for Alzheimer's disease, there are a lot of indications, multiple sclerosis, potential indications, multiple sclerosis, epilepsy, yeah, for sure. It's an expanding field, yeah.
Thank you.
Yeah, hi. Very interesting talk. So I was concerned, I want to actually to argue you are concerned about the fact that when you perform this technique, you produce an ablation, you burn tissue, and you don't know anything about the electrophysiology of the area you are intervening in. That's one thing. And another question, maybe naive, but I was also concerned about the fact of the variability of the thickness of the skull of the patients. So it may be the case that some people will receive more energy than they're supposed to receive, right?
Yeah, I will start with the second. There are some characteristics of the skull that difficult the passing of the beams through it. Only 7% of the patients cannot perform this treatment because of the skull. Most of the people has a skull that allows us to make a proper lesion. But some of them, it's a skull thickness, the heterogeneity of the skull could make it more difficult, but it's a very low percentage. The other question, it's true, we don't have electrophysiology, of course, but we have imaging, and we have MRI imaging. And in fact, so far, a lot of groups make deep brain stimulation without electrophysiology, only with imaging. So imaging has improved so much that we think we can do it safely. In fact, we also have the continuous clinical assessment that I showed. I mean, you can test with low power sonications, with low temperature, whether there is a therapeutic effect or there is a side effect. If there is a side effect, you can move your target accordingly, because the side effects usually in the STN are localizing, as with deep brain stimulation. So it's true, we don't have electrophysiology, but we have other safety measures. With DBS, many people operate without electrophysiology today.
Dr. Raúl, thank you very much. Very nice presentation. I think there is a great future to this technology, even in Parkinson's disease. I wanted two brief questions. One, why didn't you consider the GPI, instance the subthalamic nucleus? One would expect it to be easier and safer to the patient. The other one, just a comment on your hypothesis of disease modification. Deep brain stimulation in the subthalamic nucleus for 10 years, people have been trying to look for an effect on neurodegeneration. There isn't the slightest evidence in humans that DBS inactivating the subthalamic nucleus has such an effect. So I think your hypothesis is a bit, maybe you want to prolong the quality of life of patients, but to modify neurodegeneration, I think is a bit too much. I don't know what you think.
Yeah, well, I use modified neurodegeneration. In any case, it's true. The brain stimulation was proposed as a potential disease-modifying treatment, and it has not been proven. But one of the advantages of ultrasound is that you can apply it earlier. I mean, you will never operate a patient with 4 years of disease evolution because it's more invasive. With this, you can consider to do it, if we prove that it's safe and effective in the randomized trial, you can consider to do it maybe 2 years after disease onset. So, as you all know, the sooner the better to test disease-modifying effect. And this is one of the advantages. We don't know whether this will be proved or not, but we can do it with this big advantage, in our opinion. And about the pallidum, it's true, the pallidum is the other target, but first, we consider that the STN, the evidence shows, the deep brain stimulation evidence shows that the STN is more effective to treat motor features, rigidity, tremor, and akinesia, while the pallidum will be more effective to treat motor complications. And the other point is that the pallidum is more lateral than the STN, and more lateral structures are more difficult to hit. So it's more feasible to make a lesion in the STN than in the pallidum. Even though lesions in the pallidum can be done, there is a trial ongoing, we are involved in it with pallidotomy. But this trial tries to show improvement of motor complications, motor fluctuations and dyskinesia. So we decided the STN because we think it's the most effective target in PD for PD motor features.